If medicine allows a terminal cancer patient to end their physical suffering, is it compassionate or is it dangerous to offer that exact same choice to someone suffering from untreatable psychological torment? We're looking at the absolute bleeding edge of modern bioethics today in this explainer. It's a core clinical conflict forcing us to ask a terrifyingly complex question. Does psychiatric euthanasia represent the ultimate act of bodily autonomy, honoring a patient's right to choose an end to their pain? Or is it a catastrophic failure of medical care? Look, before we get into what the clinical data and the global bioethics boards actually say, I want you to pause right now. Drop your immediate gut reaction in the comments. Should mental illness ever qualify for state-assisted death? Yes or no? Put your answer down, because what we're about to uncover might seriously challenge your perspective. Section 1. Anatomy of Irremediability, the Clinical Science. Okay, let's strip away the heavy emotion for a second and look closely at the cold, hard neurobiological facts. In medicine, to qualify for assisted dying, a condition generally has to be classified as irremediable. That means the absolute inability to cure or definitively treat a medical condition. But here is the massive clinical problem we run into. Psychiatrists currently cannot mathematically prove that a brain condition is 100% incurable. Think about terminal oncology, like stage 4 metastatic cancer. We have verifiable tissue collapse. We can literally trace the tumor metastasis on an MRI. It has a clear, predictable trajectory toward death. But in psychiatric illness, there are absolutely no objective biological markers to prove that a mental illness is permanently fatal. It's just not there. Even in cases of severe, multi-treatment resistant depression, longitudinal studies show that patients can suddenly achieve late-stage remission. We're talking about profound interventions through novel neuroplasticity research, deep brain stimulation, specialized psychotherapies, and highly targeted neuropharmaceuticals. The brain can heal in ways we still don't fully understand, which makes a definitive prognosis of permanent hopelessness scientifically, well, nearly impossible. Section 2. The Paradox of Choice. Autonomy versus the disease. So this brings us to the intellectual climax of this explainer, parsing a human being's fundamental autonomy from the devastating symptoms of their disease. Think about this deeply for a moment. A core diagnostic criterion of severe depression is pervasive hopelessness and intense cognitive distortion regarding the future. So when a disease literally tells the brain that life is not worth living, how can any doctor definitively determine if a request to die is a rational, autonomous choice or simply a direct, fatal manifestation of the illness itself? It creates this extreme clinical friction. On one hand, traditional psychiatric practice is built entirely on suicide prevention. It's an ethical mandate for aggressive crisis intervention. But on the other hand, medical aid in dying is built on honoring a rational request to end unbearable suffering. So how do you legally and ethically separate a psychiatric crisis requiring rapid intervention from a rational request requiring a lethal prescription? Section 3. The Legal and Social Reality, a Global Divide. To understand how this intense philosophical debate plays out in reality, we have to look at global legislative bodies. And there's a massive global divide here. The Benelux framework, so the Netherlands, Belgium, and Luxembourg, currently permits euthanasia for severe refractory psychiatric conditions like complex PTSD. Conversely, in the US, the UK, and Australia, eligibility is strictly restricted to terminal physical conditions, usually with a prognosis of 6 months or less to live. Mental illness is explicitly excluded. And then you have Canada, caught right in the middle. Now, it's vital to note that even in those Benelux nations where psychiatric assisted dying is legal, it remains incredibly rare. Psychiatric cases represent just 1 to 3% of total reported euthanasia procedures. But you have to admit, the ethical weight of that tiny percentage is staggering. Which explains exactly what is happening in Canada. They initially planned to expand medical assistance in dying to individuals whose sole underlying condition is a mental illness, but Parliament suddenly halted. They delayed this expansion to March 2027. Why? Because their medical bodies explicitly stated they need way more time to evaluate diagnostic certainty and figure out if adequate clinical safeguards are even possible in psychiatry. This brings us to a deeply uncomfortable question regarding social determinants. Are some patients seeking an exit because their brain state is truly untreatable, or are they seeking death because systemic resource gaps left them structurally vulnerable?
Disability rights advocates fiercely argue that requests are compounded by chronic poverty, trauma, and completely inadequate access to specialized psychiatric care. We really have to ask ourselves, are we treating an untreatable disease, or are we simply euthanizing the victims of a failed social safety net?
Section 4. The final debate. Synthesis of the dilemma.
Let's lay out the two moral sides side by side, strictly looking at the ethical foundations, with absolutely no judgment. Argument A champions bodily autonomy. It states that denying mentally ill patients the right to end their unending suffering is cruel and inherently paternalistic. It forces them to suffer in ways we would never, ever force a terminal cancer patient to endure. But argument B warns of immense danger. It argues that offering death as a psychiatric treatment completely undermines suicide prevention, sends a dangerous message that recovery is impossible, and ultimately abandons our most vulnerable populations when they need aggressive care the absolute most.
Which leaves us right back where we started, but now armed with the heavy clinical realities. Is psychiatric euthanasia the ultimate act of human autonomy, or is it a catastrophic failure of medical care? Take everything you've just learned from this explainer, look at the science, the paradoxes, the legal delays, and the social realities, and let's continue this intense clinical debate. Go to the comments section right now and tell me where you stand. Has your opinion changed? I'll see you down there.